Dr. Kimberlin, if you would like to start.
Well, first, I'd like to thank everyone for taking time out of what I know are busy days to talk about an important topic that doesn't seem to go away, does it? It just is the gift that keeps on giving in terms of this pandemic. So we're tired of it. We have to deal with it. And if we don't deal with it, it's going to deal with us regardless. So we have to be ready. We have to be mindful. We have to be cognizant of where we are in this pandemic. And right now, it's not a good place. I think that's kind of stating an obvious sort of a comment there. There are some good news developments, though. One of them is an announcement that came out this morning. I think there probably will be additional questions about it. And if I think about things from the pediatric standpoint, this is perhaps one of the highest important topics that I can think of. And that's specifically, when are we going to have vaccination opportunities options available for 5 through 11-year-olds. As you all know, we have the Pfizer vaccine that is authorized for 12 through 15-year-olds, and the Pfizer vaccine is approved for 16 years of age and above. So we're good from the 12 and over standpoint. We still have issues in terms of more families needing to have their adolescents vaccinated. Those can be additional conversations throughout the next 30 minutes, but at least we have an option. Now, the news from today, and this is a press release, it's a press release from Pfizer, and science is not good when done by press release. So keep that in mind. But nevertheless, it's a foretaste, if you will, of what we expect to be seeing. We need to see it with our own eyes. Expect to be seeing from the Pfizer data set. They have done a relatively large study in 5 through 11-year-olds. The dose of the Pfizer vaccine that is being evaluated in that age group is 1/3 of the dose that is used for 12 and over. So it's not simply just drawing out of a vial that's already approved by the FDA. This is a different formulation of the same vaccine, different amount of the vaccine that will be given to these younger children. And what Pfizer is saying is that their safety data look good and that their immunogenicity data look good. In other words, how strong, how robust is the immune response in a child vaccinated with that 1/3 dose compared with an older adolescent with a young adult and so forth. And so that hopefully, if the numbers really pan out when we look at the data with what the press release is saying, then, this should be before the FDA for their consideration of authorization, during the latter part of September and into the first half of October. And what a lot of folks, Dr. Fauci and others, have said is that they anticipate we may have an authorization before Halloween. And that would be a tremendously positive step forward. Now, as I say, the scientists have to lead this. This is not a politician-led type of a process. This is a data-driven, science-driven process. It has been the entire way through. And that's reassuring to me. I think it should be reassuring to every American out there. So I don't want to get too far ahead of myself, but I'm delighted by the timelines. The timeline has always been for Pfizer to get their data set completed the latter part of September, and they hit that mark. Now we need to look at the data. Now, I'll also add that Moderna has done equally good studies. Moderna, if you think back over the course of this pandemic, they've always been about a month or so behind Pfizer. I don't know why that is. That just seems to always be sort of the pattern. And as far as I know, Moderna is set for, an October kind of filing with the Food and Drug Administration for possible authorization of their 5 through 11-year-old age group as well. I know less about that than I do about the Pfizer data set and where the Pfizer study is. So I'm hopeful that we'll be able to see FDA receiving those data and really considering those data and hopefully making an authorization for 5 through 11-year-olds. That's a big development.
All right, thank you. And Dr. Lee, would you like to provide your opening statements?
I think, this is a very difficult time in this pandemic. I think when we talk to healthcare workers, it's one of the hardest surges to deal with. I mean, the fact is, this is a vaccine preventable illness, and we are seeing just a large surge of patients that are otherwise healthy and very young on the adult side being admitted. I will say that hospitalizations and new cases across the United States do appear to be coming down. It's very, very slow compared to the last surge. So we've had an 8% reduction. But as everybody is aware, deaths always lag behind hospitalizations. And so our death numbers are increasing in the United States and in Alabama. In fact, in Alabama, we've seen a 177% increase in deaths over the past 14 days. And that's very sobering when you think of how many people we could be preventing illness and preventing death with vaccination. I will say at UAB, we are seeing a slow downtick in our numbers of hospitalizations, but we are still very full as a hospital, and across Alabama, ICUs are very, very full right now. In fact, 50% of the cases in ICUs right now are due to COVID-19 patients.
Hannah, if I could just give a visual on that, because I think what Dr. Lee said is exceedingly important. I think about, the TV images after massive floods, where people are on their rooftops and getting picked off their rooftops by helicopters. That's kind of where we are. And what I think Dr. Lee is kind of getting at is the water is no longer rising, but it's not really dropping very much either. I mean, we're still at the roof line here. And so that, when people hear things are getting better, this isn't, like freedom. This is still exceedingly dire, just as would be the case if you're looking at a TV screen of a massively flooded region of our country and you see just the rooftops above the water. Now, it's not going up any higher right now, and that's good news. That's good news. We should celebrate that. But we have a long way to go before that water recedes.
Thank you, Dr. Kimberlin. Kind of going back to the Pfizer announcement, what does this mean for schools if we do get an EAU for the 5 to 11, and how kind of important is it for this age demographic to help us really control the pandemic?
Well, my thought on that is that it's exceedingly important. I take care of children and adolescents here at Children's of Alabama, and I've been on service these last couple of weeks, and we have a lot of adolescents that are in the age range where they could have received the vaccine, but we have a lot of children under 12 as well that are admitted to the hospital with COVID. So it's important from the standpoint of protecting those children so they don't end up in the hospital, end up in the ICU, end up on a ventilator, and so forth. It's also critically important from the standpoint of our larger community. Children under 12 years of age do not make up an insubstantial percentage of our population. And right now we have no way to try to prevent, other than regular standard things that we know work, masking, social distancing, and so forth. We don't have a way to really ward off them getting infection with COVID, the COVID virus. Now we will, if and when this authorization occurs for 5 through 11-year-olds. So it's important from the individual standpoint, and it's important from the community standpoint. If we can protect more children in schools, then those schools stay open. And that's what we all want. Now, what we've also seen is, and we saw this pattern with healthcare workers, and then we saw it with the general public back in the spring rather, and then we saw it with adolescents as we moved into the latter part of May and June. There's this rush when an authorization occurs. There's this rush of people going out and getting vaccinated. That's good. But then it levels off and people go, well, I don't have to do it with my child. Well, yeah, you do. You got to do it, number one, to protect your child, which every parent wants to do. But you also have to do it for your child. And if you're not vaccinated yourself, to get the vaccine. For all of us, we are not going to put this pandemic behind us until more people are vaccinated. That's just a fundamental fact.
All right, thank you. I see from some of our participants that they are seeing a decline kind of in clinics of cases over the past few weeks. So, do we think that we're on the backside of this surge? Or are y'all surprised that cases are tapering off? What does this mean? Is it a signal that we are on the backside, or is this something cyclical?
So anytime that we have a surge, it's very interesting that you can expect about a 2-month period of time where you'll see an increase in cases and then coming back down. When you look at the data with Delta, it is much longer, it appears. We've started this back in July. Now we're in September and we're still in the surge. I think we have to be very, very careful in thinking that we've kind of won Delta and we're going to be fine and we can take off our masks and go to big parties. We need to do everything that we can to continue to reduce transmission. Like Dr. Kimberlin said, vaccination by far and away is key. But wearing a mask and making sure that you stay home when you're not feeling well, getting tested frequently, all of those things help us as a community to get out of this pandemic.
Okay, thank you. Can we talk a little bit? I know that ivermectin has been a hot topic in the news lately for people wanting to treat COVID. Can y'all talk a little bit about ivermectin and also specifically ivermectin in children?
Yeah, it doesn't work. So don't use it. And that's the gist of it. The so-called data out there about it are just nonsense. The blunt assessment is it does not work and it has harmful side effects. Don't use it.
Yeah, I think it's helpful to understand how it even came into being, why we were thinking ivermectin works. And so what they did was they looked at a lot of different medications, including hydroxychloroquine and some HIV medications. They put it all on a plate to see what would kill COVID-19. And I will say these are incredibly high doses, very, very high doses for ivermectin. And so with each of those, they have had studies and trials. Hydroxychloroquine had randomized controlled trials that did not show any benefit, as well as the HIV medication lopinavir-ritonavir, which didn't work as well. And so now we've come across ivermectin, and all the data, like what Dr. Kimberlin is saying, it does not show any sort of benefit, and potentially it is showing harm, as we have seen some people being admitted with excessive amounts of ivermectin and consequences from that.
And we're still getting, like, to our poison control center, we're getting way high numbers of calls about ivermectin. It just, I don't know where it's coming from, but folks, it's like the FDA said, you're not a cow, you're not a horse. Seriously, guys, stop it.
Yeah, I think, the way that Dr. Kimberlin and I use this medication is really for parasitic treatment. And so it has great data for that, but not for COVID-19.
All right, thank you. Are there any concerns about myocarditis in young males receiving the vaccines? How would you compare kind of those concerns over the risk of that age group getting the actual virus?
Well, there is a correlation between, especially second dose in people who are mostly older adolescents and young adults, mostly males, can be women too, young women, but it's mostly in males, between the mRNA vaccines and myocarditis. It is, when it happens, exceedingly rare. It is short-lived. The average duration of hospitalization is like 2 days or something like that. It's treated with things like ibuprofen, Advil. It isn't a serious kind of thing. And a couple of points here: you are 3 times more likely, based on the current data, you're 3 times more likely to get struck by lightning than you are to have myocarditis following receipt of an mRNA vaccine. And if you get COVID, you are many times more likely to have myocarditis from the disease than you are from the vaccine. So it is something that is real. I'm not going to, we have to follow the data. The data do show that there's a linkage there, but it's very, very rare. It's really quite inconsequential. And you're much more likely to get it if you don't get the vaccine and you get the disease. And with this, heat-seeking missile kind of Delta variant that'll find people that are not yet vaccinated or immune, you're at a pretty high risk of getting the disease right now in the state of Alabama. So it is something that is real, but rare.
All right, thank you. Dr. Kimberlin, I know that you were talking earlier about how stuff's not necessarily going up, but we still have a long way to go before, it's a lot better. Can you just give us an overall of what we are seeing with pediatric cases and COVID in Alabama right now?
Well, yes. And of course, it's fluid. Things change, maybe tick a little bit better and then tick a little bit worse and so forth over the course of days. For the last several weeks, we have been running pretty consistently at Children's of Alabama 2 to 3 times more COVID hospitalizations than we were having back at the worst part of the pandemic in January of this year. So that is continuing. We're, I think today, like about double where we were in January. These are mostly people who are sick with COVID. These are not the incidental, coming in because they broke their arm and they happen to test positive. That's not what we're talking about here. And a whole lot of them, third or so, end up in the ICU. Several on vents. We have some on heart-lung bypass machines. I mean, this is serious. And I don't know if I've yet been able to say that I've seen enough of a decline to say that we're kind of emerging from it right now. I hope that we do, and we will eventually. But as Dr. Lee is kind of able to track with the larger numbers of adults at University Hospital, because there are more adults than children, there's larger numbers of hospitalized adults. They can kind of see the trends sooner than our lower number of pediatric cases allow us to see.
I think it's helpful to mention here that children really should be protected as much as we possibly can. This goes back to what we do have and what we don't have for kids. We do not have vaccination for a large proportion of our children. And so what can we do to protect them? I mean, on the adult side, I can tell you, I was just on service, and it's incredibly hard to see people younger than myself with no comorbidities intubated and on the ventilator. This is important data. It's more than just numbers. It's a person that you love, that you care about, that is really struggling and hospitalized. And so that's why we as a community need to work together to protect our loved ones.
All right, thank you. And kind of going back to the vaccines, I know that we talked about the dosage is about a third of an adult dosage, but are there any concerns for maybe 10 and 11-year-olds who have maybe BSAs comparable to adults with this smaller dosage?
We need to see the data. I will say that up until this point, and presumably still with this new data set, our dosing has been age-based, not body size or weight-based, which can be a little different. Sometimes we do a lot of times we do weight-based things in pediatrics, but the way the studies were designed, it's an age correlated recommendation of what the dose should be. And a lot of that is because no matter what size we are, our immune systems develop over time. They start out quite immature as a baby's immature, and then they improve to the point, develop to the point where they're much more like an older child than an adolescent, and an adolescent's much more like an adult. So it's really more of an age-based maturation of the immune system that tracks with what the response to the vaccine is, at least as we know now. Now, I don't want to get too far ahead of myself because I have not seen the 5 through 11-year-old data set yet. And as I said before, this has to be data driven. That said, as I understand it, that's the rationale for why they went with that 1/3 dose, because they were seeing that in the younger children, they just have such a better response to any kind of an infection or a vaccine compared with an older person, that was the dose that gave the kind of response that they wanted to see.
I think the data in this press release, and I agree with Dr. Kimberlin, press release is not the best way to, really truly understand data. But what they did say was that they compared this 5 to 11-year-old group to ages 12 and over, and they had very similar antibody responses. So I think that's reassuring. It would be interesting to see how many were in their groups and, whether or not there was this difference based on older age, but we have more to come there.
Okay, and then kind of with the kids that we are seeing hospitalized with COVID, are we seeing a lot of comorbidities with these kids? Yes,
in many, but not all. Some are perfectly previously normal, healthy kids, no comorbidities. Many do have comorbidities. It's similar to the adults. And if you look across the scope of the pandemic, about 40% of children, this is overall, where we have more data published in the literature, about 40% of children have no comorbidities. About 60% do. So certainly there are things that put some children at higher risk, but we're all at risk. Until we're on the other side of the pandemic, all of us are at risk.
Yeah, I think there's some data floating around about how the kids that have died from COVID-19 have had comorbidities, but I think that is very hard data to really put your hat on, because what you're essentially saying is that, well, they were sick anyways, and so therefore higher risk. But, you know, we don't want children to have this. We don't really expect children to die. And Dr. Kimberlin can go and talk about how, you know, kids typically bounce back from things, and we are not seeing that here, and we have to recognize we need to protect our kids.
So let me just add, if you go to a high school football game on Friday, look around the high school football field. Those are the children that are dying. I mean, that's what they look like. These are not, medically frail. Well, sometimes medically frail, definitely, but these are otherwise rather unremarkably appearing children. They look like your children, and they look like my children.
All right, thank you. I know that we have started to see a decrease in cases, but even with these decreases, and schools have started to, lift some of these masking requirements. How long do y'all think that schools should be masking?
Indefinitely. The way to do this is to follow the CDC, and the CDC, they did back in May, they did kind of treat it like a light switch. It was on and then it was off. Now, in their defense, when they switched it off for vaccinated people, and too many unvaccinated people said, well, we're free as well, and they stopped wearing masking. So in defense of what they did, it was it wasn't followed to the T based on what the recommendation was on May 17th or whenever that was, May 14th. But what they've done now is they make it much more like a rheostat, where you can dim the light or turn up the light in your home. And what they say is, if you're in an area of substantial or high transmission, then everyone unvaccinated should wear a mask indoors, and everyone vaccinated should wear a mask indoors. And then when you get down below the substantial transmission, everyone unvaccinated still needs to wear a mask, but the people who are vaccinated do not have to wear masks inside. So what we need to do is simply watch our transmission in our county or community and see where we are. And right now we're still in high, which is the worst. I mean, that's the reddest of the red on the CDC website. So in my judgment, we follow the CDC, that's the best way to do it. And that doesn't mean we're masked in 2025. As the numbers do decrease, as the rates do decrease, and we drop below substantial, then we can loosen up some. But the idea of as some school systems have done, saying that, well, these 2 weeks of wearing masks has worked really well, so let's stop wearing masks. That just doesn't pass the sniff test. That doesn't make sense. And yet that's what many schools are doing. And I can promise you what's going to happen. Cases will come roaring back, and then they'll have to redo it all over again. And there'll be a lot of virtual people learning. And I mean, it's just silly. Let's just do it the right way, stay the course, and get to the other side of this.
Yeah, I have a 6-year-old and a 10-year-old, and I talk a lot with them about masking and about the importance of distancing. And if you ask a child, would you rather be in person or would you be in quarantine but not wearing a mask? I can tell you what their answer is. They want to be in person learning with their teachers. Their teachers are prepared to help them learn. It's a lot harder as a parent to be able to work as well as to help them with their virtual learning. So, masking is a very simple intervention. It is safe. It is effective. It's not 100% effective, but it is effective, and it's one of our many layers of protection that we have during this pandemic.
All right, thank you. I've got a few more questions for y'all. We might go a little bit over time if that is okay. But if a child has tested positive for COVID, how long do their antibodies work? Can they get the virus again?
I think, to my knowledge, the pediatric data really track with the adult data, and Dr. Lee can speak to the adults much better than I can. What I will say is that, yes, people who have had the disease before can get it again. That's well documented. And the immune response following natural infection, and this is in children as well as in adults, the immune response is less broad, it's less deep, and it's less long lasting. It's not as good as the vaccine. It provides some protection, but it is not as robust a protection as you get from getting the vaccine. So the older data were 90 days. They said you were protected. I guess, Dr. Lee, that's still kind of the accepted timeline, although my strong advice is as soon as you're over the disease, get vaccinated if you're 12 and over, so you then get the real long-lasting benefits.
Yeah, I completely agree. I think there's been some terms, like, it's funny how we're all learning about our immune systems, during this pandemic, but there are a couple of terms that have been thrown out that you may have heard of. So one is neutralizing antibodies. So, right after you've been infected, if you develop those antibodies, which I will say about 30% may not develop antibodies to begin with. But if you do develop them, those are those neutralizing antibodies that are kind of waiting in the wings. And so if you are exposed again, they can quickly go there and destroy the virus. But then we have something called memory cells. And so those take a little bit longer. If we had those in our bloodstream 100% of the time, like, our blood would be like sludge because we would have so many different immune cells in there. So we have them in these memory cells, and then once we're exposed, then it takes a little while to develop those antibodies. So the memory cells, it looks like they last for about 8 to 10 months. We're still continuing to learn. It's those neutralizing antibodies that seem to be waning, both in people who are fully vaccinated, which we're still continuing to learn about, and then also potentially those who were naturally infected.
All right, thank you. Another question. This is more for kids who have had COVID. Some parents want to know, are there any kind of medical follow-ups that they should do? Testing for myocarditis, maybe long haul COVID, stuff like that.
Well, that's a very good question. If your child has MISC, that multi-system inflammatory syndrome of children, that hyperinflammatory condition that will follow by a handful of weeks, having had the infection previously, recognized or unrecognized infection previously. If you have that, then it is important that you get followed. And we have a MISC clinic, multidisciplinary clinic, where we follow those children along with cardiology and rheumatology and infectious diseases. For not MISC but acute COVID, coming in with or having at home the respiratory symptoms or the difficulty breathing, those kinds of things. Right now, there's not a standard follow-up because there's so many of them. There isn't enough capacity to follow every single child just as there's not a capacity for every adult as well, because we have too much virus out there. There are too many people getting infected. But your pediatrician is going to be your best, main contact. Go to her if you're seeing something concerning to you as a parent, and then she or he can look into it further and then pull in specialists as needed. This long haul COVID, which is I think there was one study out of China recently that showed 49%, so basically half of people still had one or more symptom a year after 12 months after having had COVID. We are seeing some of that in children as well, and that's all the more reason to go out and get your vaccine. Don't roll those die. I mean, don't do it. Don't play that Russian roulette. Get the vaccine, protect yourself, protect your family, protect your community, and then you don't have to worry about the long haul COVID issues.
All right, thank you. I've got 2 more questions and then we'll wrap up. I know that there was some announcements with boosters last week. So aside from boosters, do we know if or when those who are fully vaccinated will need to get vaccinated again, like we do with influenza vaccines?
So I think we're still learning about that. The first thing is to tease out, for people who are immunocompromised, there's already a recommendation if your age is 12 and up to go ahead and get that 3rd dose. So consider it like a completion of your primary series. And so you can go to the CDC's website. It does define who is considered immunocompromised and who should be getting a 3rd dose. And then Pfizer met on Friday to discuss 2 different questions regarding a booster shot for people who are not in that category. And so the first question was whether or not a 3rd dose is safe. And then the second one is whether it's effective. And so the safety data is pretty good. It seems that the third dose is very consistent with the second dose. About 65% or so can expect fatigue, about 50% can expect headache. So very similar side effects. Pfizer did present about data from 300 people, and then Israel presented their real world data saying that they only had about 19 out of 2.8 million people that had an adverse event. The second question is much harder, right? It was looking at the effectiveness of the vaccine. And Israel gave a lot of their real world data and modeling that where they found that giving a third dose can help with reducing further cases of severe COVID-19 and also potentially help with transmission. Now, we do not have full data on that yet, and we're still trying to kind of suss that out. But I will say that there is pretty good evidence for age over 65 that it is recommended that we will likely get a booster for that age group. Now, it's only gone through the FDA. It then goes to the ACIP, which Dr. Kimberlin can talk more about as he's part of that group. And then from there, we'll make recommendations to the general public.
I'll just very briefly add, what Dr. Lee was talking about on Friday, that was that external advisory group of scientists to the Food and Drug Administration. And, again, to me, I thought it was a robust meeting. I thought it was fascinating to listen to. And it showed that the process is working the way we want it to. We're following the data. We are not Israel. And there's some differences in the way the Israelis define, for instance, severe disease compared with how we're defining severe disease. There are differences in the way and the speed with which they were vaccinated compared with the United States. There's just some fundamental differences. And we need to know what the scope of the protection is in the United States in order to make important recommendations like routine booster doses. And the committee that was looking at this external advisory committee said, well, we're not seeing it right now. We're seeing it for probably the 65 and older and others at high risk, perhaps. But now the ball is in the FDA's court. FDA usually follows the advice of their external advisors. They don't have to, but they usually do. So we'll see what they do with respect to authorization of booster doses. And then when FDA makes a decision on assuming they decide to authorize booster doses, at least in some populations, then as Dr. Lee said, it goes to the CDC's Advisory Committee on Immunization Practices, or ACIP, another external group of experts who advise the CDC on who should receive, in this case, a booster dose. So we have these multiple levels of scientific review looking at the data, not the we wish it could be this kind of stuff, but what do the data show us, and where are we going with this, both safety and beneficial aspects. And I find it to be very reassuring. It's confusing a bit. I do acknowledge that, because you hear, well, everybody's getting a booster and then only 65 and over, and it is jumping around a bunch. But help ride this one out with us, because at the end of it, we're going to have the data and the scientists making the recommendations. And I suggest that's a very good thing.
I feel like the community has had a taste of the true scientific method, right? This is what we are doing in a pandemic. We're constantly learning and we're adjusting what we know based on that. And this should be reassuring to the community that we are basing all of our decisions on science.
All right, thank you. And kind of our last topic before we wrap up. Is there any kind of timeline for those who are under 5? And what are kind of y'all's suggestions to best protect those age groups that are not eligible for the vaccines?
Well, I'll start with the under 5, and we know less about what that trajectory is, but what I understand is it suggests that it's not really deviated much from what we thought it would be earlier in the year, and that is by the end of this year and perhaps the very first part of 2022, that's when the data for the 6-month through 4 years of age cohort will be available. So I am hopeful, data permitting, that we get 5 through 11 by the end of October. I don't think under 5 is likely. My best guess would be early 2022. And by early, I mean like January and February kind of months, but I'm guessing with that.
And to your second question, I think it is really hard for parents right now who have unvaccinated kids, to be in the height of a surge and wanting the best for their family. So continue to mask up. It is important if you're fully vaccinated to mask around others and to mask when you're indoors in particular. Ask your kids to mask, teach them how to wear a mask appropriately. Also keep them home when they're sick. If they, even if it's runny nose and slight cough, we want to make sure that we're not adding to transmission in our communities. And then last, I will say, and I think about this a lot, it's important for the mental health of our kids to be around other kids. And so how can you do that safely? Well, being outdoors and continuing to distance outside is very important for them because they continue to be with kids their age group. But it also, we have good data that shows that, if you're outdoors, you're less likely to transmit. So think about that in terms of the health of your children.
All right, thank you. And then Dr. Kimberlin, do you have any final words?
No, I appreciate everybody's ongoing interest in this. I know we are all tired, and sometimes when you're exhausted, you just kind of want to just throw in the towel and say, to hell with it. I'm going to do what I want to do to get back to normal, and I understand that it's not going to work. And so let's do what will work. And it's exactly what Dr. Lee said. Wear a mask inside, whether you're vaccinated or not. Be outside as much as you can. Get vaccinated if you're 12 and over. And then hopefully, within a month or so, 5 through 11. And the only additional thing I would say is, like, if you go into a big box store, a grocery store, or something like that, and they don't have a sign on the door saying, masks required, politely pull the manager aside and said, I'd really be more comfortable if there was a requirement that people coming into this business, have to wear masks. That would make me feel a whole lot better. You don't have to say anything more than that, but if they hear that enough, then that will counter what they also hear on the other side from the loud, angry people that don't like masks for whatever reason. I don't get it. But anyway, they don't seem to like masks. And so I think that's important. And a business will want, number one, they want to do what's best for their customers and for their employees. And that might be just enough to kind of help them get pushed in that direction. So we have to be loving. We have to be polite. We have to be. But we don't have to be silent. We can also say very politely, I sure would be more comfortable if this were the case. And I would encourage people to realize the power that they have and to exercise that power. All
right, thank you. And Dr. Lee, any final words?
No, I think I agree with Dr. Kimberlin. We're all exhausted, and we really, doctors included, don't want to be in this pandemic anymore. We want to be able to go back to having friends over easily without having to be concerned about symptoms, being able to take off our masks as well. But if you guys can hang on and for just somewhat longer until we can get all of our, as many people as we possibly can vaccinated and get us out of this pandemic, I think that would be the best for our community.
All right, thank you. And thank you, Dr. Lee and Dr. Kimberlin, for joining us today. I know we went a little over. For everybody who's joined, I'm sorry if we could not get to your questions. I encourage everyone to visit uab.edu/news. That is where we put out a lot of our updates, a lot of great COVID information there. Also follow us online at UAB News, follow UAB Medicine. Those are great resources. And then I would also like to remind everyone, if you are looking for a place to get vaccinated, UABmedicinevaccine.org is a great place. And then our Hoover Met vaccination site is open Monday through Friday from 8 a.m. to 1 p.m. No appointment necessary. This is free. We are also opening another vaccination site on Wednesday, September 22nd at Faith Chapel in Wylam. That will be Monday through Thursday from 8 a.m. to 1. Thank y'all for joining us, and I hope everyone has a great day.